Good afternoon, and thank you very much for the opportunity to contribute to this second annual Computational Data Neuroscience Symposium. My name is Francesco Sala. I'm a professor of neurosurgery at the University of Verona in Italy. And my only disclosure is that I'm not at all an expert in machine learning. However, I've spent quite some time over the past 22 years in the field of intraoperative neurophysiology, and I would like to share with you the idea that maybe machine learning and big data analysis may definitely implement neuromonitoring in the years to come. So what is intraoperative neurophysiological monitoring? Well, according to Fred Epstein, one of the pioneer pediatric neurosurgeons who unfortunately passed away in 2006, but was one of the strongest supporter within the neurosurgical community of intraoperative monitoring. Fred says that neuromonitoring is likely one of the major achievements in modern neurosurgery. Intraoperative neurophysiology is not a tool. We use many tools in the operating room. But this is not just a tool. It is a discipline, a subspecialty of clinical neurophysiology, where we use neurophysiological techniques, evoke potential in a different environment, which is the operating theater, with a different goal, which is not to diagnose a disease, but rather to prevent a iatrogenic injury during neurosurgical procedures. It is by all means considered the practice of medicine, which implies credentialing, who does what, in neuromonitoring and training. And training is a big problem. It's a big problem because it takes quite a long time to train somebody in neuromonitoring, and obviously the quality of monitoring depends on the amount of expertise you have accumulated over time. Probably every training program will require at least 12 to 18 months of practice, and very few centers have a caseload that can warrant this exposure to neuromonitoring. And the problem we have been facing over the last decade or so is that neuromonitoring has become very sexy. It's very trendy to say that you are using neuromonitoring during your operation. There is a big business behind neuromonitoring with companies providing this service, to the point that we end up facing a big discrepancy between the demand for neuromonitoring and the supply in terms of neuromonitoring professionals. And as you know, when there is a big discrepancy between demand and offer, the temptation is to take shortcuts. So, for example, one of the shortcuts is to use remote monitoring, which means you have a neuromonitoring professional sitting in Boston monitoring a surgical procedure in New York. And this nowadays represents probably more than 50% of all neuromonitoring in the United States. There are also the so-called automated neuromonitoring systems. These devices are advertised as machines that can basically surrogate for the lack of neuromonitoring professionals, providing the same technical capabilities of monitoring technicians. So the idea behind is that you can replace the thinking brain of somebody who has been trained in the field for years with a black box which performs an automated analysis of the signals and then offers to the surgeon a green, a yellow, or a red light on the basis of which he should tailor his surgical strategy. Well, this has been considered for many years bad monitoring, and the adagio has always been that no monitoring is better than bad monitoring. However, I wonder if in the near future, machine learning may represent good monitoring, a good quality of neuromonitoring that can support these activities, these disciplines around the world when there is not enough manpower to provide services. More recently, also the so-called surgeon-directed neuromonitoring systems have become very popular, especially in spine surgery. Again, these are advertised as reliable tools to identify neural structures and monitor their functional integrity. Technologies and neurophysiologists are not needed, and no specific training for the surgeon is required, that you may understand what this means. So although there are circumstances where surgeons may not strictly need a monitoring professionals in the room, I think that they support the idea that monitoring expertise are irrelevant, represent a threat to our patients and also to ourselves. So more in general, I'm very worried that we are going towards a fast food approach to neuromonitoring rather than a slow food approach, which means proper training and education. So if we look at the techniques we use in neuromonitoring, there are monitoring techniques which are aimed to continuously assess the functional integrity of neural structures like somatosensory, motor, auditory, visual, evoked potentials, and mapping techniques which provide functional identification of ambiguous neural tissue. Now, most likely from the point of view of machine learning, monitoring techniques are more relevant. So this is what we use when we do cortical or transcranial motor evoked potential, somatosensory evoked potential, visual evoked potentials, auditory, brainstem evoked potential, etc. These are the classical monitoring techniques. And what we do? Well, we look at signals, like for example these muscle MEPs from the upper and lower extremities, or these corticobulbar MEPs from the glossopharyngeal and apoglossal nerve, or these SEPs from the dorsal column pathways during a spinal cord tumor. And sometimes we see that something is wrong. For example, during this myelotomy, the SEPs were dropping and disappearing. So we monitor these signals to see if they remain stable during the surgery or if they deteriorate. And of course, there are warning criteria that we can use to predict the outcome and, most importantly, to prevent neurological injuries. But what complicates even more the interpretation of these signals, besides the surgery itself, is also the fact that they are very sensitive to blood pressure, anesthesia, the use of muscle relaxant, room temperature, etc. So the interpretation is rather complex. So in short, the interventional cascade is based on the fact that there is a diagnostic test which is interpreted by the neuromonitoring professional. This is then communicated to the surgeon, and the surgeon is ultimately the one who takes an intervention on the basis of which we will have different outcomes. Now, the question is, can we do something better in the future? For example, can we better understand the composition of the electrophysiological signals and use the emerging patterns as prognostic factors? Can we combine organically the different data streams that we have and then describe the intraoperative situation of the patient? Or can we anticipate in real time the occurrence of signal deterioration in order to allow the surgeon and the anesthesiologist to change their strategy? Now, this is probably where machine learning can come into play. Why? Well, because the nature of the electrophysiological signal is such that it can be analyzed very well with the principle of machine learning. There are multiple analytic techniques that can be used, like the supervised and unsupervised learning. And of course, we have been accumulating and continue to accumulate big amount of data in neuromonitoring all around the world. So the nature of the signal, there are already examples of how you can use machine learning to analyze EEG or EMG signals. We also have in neurosurgery already example of offline analysis, for example, of electromyographic signals in vestibular schwannoma surgery to predict the outcome of the facial nerve. And we know that the so-called A-train correspond very well to a postoperative paresis. But probably with machine learning you can do even better than that. This is another example in the analysis of the prediction of seizure, analyzing EEGs. I'm not expert again, but I'm learning now that you can have supervised or unsupervised learning system So with the supervised approach, you basically teach the computer how to recognize patterns of muscle MEPs that you already know and see if the system is able to recognize these signals and also recognize anomalies. On the other hand, a more complex approach is the unsupervised learning approach, where you can in the end unveil hidden signals, components, or patterns that can help you to further improve the interpretation of neuromonitoring signals in the future. So this is something brand new for us, and I'm going to conclude just with an old slide. This is what I've called Once Upon a Time Machine Learning, Verona 1978. This was a paper published by my former chairman, Professor Bino Bricolo, who spent many years investigating the role of EEG analysis in predicting the outcome of comatose patients. And if you read this abstract, which is almost 42 years old, you will find some of the principles that are at the basis also nowadays of machine learning. So for us, this is to some extent to go back to the future. And I'm very pleased of this new collaboration with the CNOC Center at Harvard. I'm very blessed with the arrival in Verona of Alessandro Boaro, who spent 2 years in Boston with your team and now has joined us for his PhD program. And I look forward to a close collaboration, and I hope that in the years to come we may come up with some new ideas to further implement the value of neuromonitoring with the contribution of machine learning. Thank you very much.